I'd like to welcome everyone to the Vasculitis Foundation's webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series, and I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. And in today's webinar, we'll be talking about polymyalgia rheumatica with Dr. Sebastian Satui. And after we finish this webinar today, there'll be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who registered today will receive an email with a link to it as soon as it's available. I'll introduce our speaker for today. Dr. Sebastian Satui is the director of the University of Pittsburgh Medical Center's Vasculitis Center. He's an assistant professor of medicine at the University of Pittsburgh, and his clinical practice and research are focused on the care of people living with vasculitis and/or polymyalgia rheumatica, as well as the intersection of aging and chronic inflammatory diseases. So welcome, Dr. Satui. We're so happy to have you with us today.
Thank you, Kathy, and thank you again for the VF for the invitation to talk about PMR, which is certainly I think as most of the things that I talk about when I'm in kind of meetings or sessions with the VF are very topics that are very close and dear to my heart, that I get the honor to actually help and care for people who live with these conditions as well. So I'm going to go ahead and share my screen. Go ahead.
Just before you share your screen, I was going to run the polls and also.
Oh, yes. Let's start with the poll questions, which we created this questions just to get a sense of a little bit of knowledge or what has everyone been told or heard or know about PMR. So you can go ahead with that, Kathy.
All right, so let's just launch the surveys and see. Hopefully everyone can see the survey now. 3 questions there. You'll see how long after your diagnosis were you referred to a rheumatologist. You'll also see the second question is, if I have PMR, am I at risk of developing giant cell arteritis? And the third one is, PMR is a disease that requires treatment only for 1 to 2 years. That's a true or false question. So we'll give everybody just a minute to answer all this. Okay, very good. Let me end the poll now and let Dr. Satui look at the results. Can you see those results now?
I can see them now, yes. And I guess the questions are a bit of a mix. The one is more to like everyone's experience in the sense of healthcare in the care of PMR. And this is actually, I guess, something that is to some degree, and we'll talk about this during the kind of the presentation, but the first question that we did was, how long after your diagnosis were you referred to a rheumatologist, right? So unlike a lot of other rheumatic diseases, we do know that people with PMR can be, in some scenarios, primarily cared for or exclusively cared for in the primary care setting, which is very different when you think of any of the other vasculitides or any of most of the rheumatic diseases. But it seems that most people, 52% of the people who have answered, said that they were referred to immediately to confirm the diagnosis. That 29% were referred to after 3 to 6 months, and then 19% after 1 year. And that certainly has some implications, not only from a diagnosis standpoint, but also kind of some of the options, therapeutic options, and the assessment that we will discuss about today. It seems that everyone has seen at least a rheumatologist once or maybe remain under care. Then the next 2 are more of kind of knowledge and some, I would say in some scenarios, inaccurate myths about PMR. But the first one, which is, I'm glad to see 100% answer there, is if I have PMR, I'm at risk of developing giant cell arteritis, and everyone answered true for that. So gold star for everyone, and for your physicians who have actually educated you correctly on this. And then this is something that we'll talk about that today as well, is PMR is a disease that requires treatment only for 1 and 2 years. Most people said false, which I would agree with that. Someone 6%, someone said true. And we can talk a little bit about that, because I think unfortunately there's There's some misconceptions about this as well, which has probably led to some of the challenges in the care of PMR and understanding as well. So we'll talk a little bit about that, because the true answer is no, it's not set in stone that this is a disease that lasts for 1 to 2 years. And we'll talk a little bit about that on the slides. Okay, so thank you so much for that. I could have a million other questions of what are your thoughts or what you have been told about this, but we'll leave it for later as well. So I'm going to now share my screen, which at this point, I think everyone is seeing this big blue screen that says Polymyalgia rheumatica. Wonderful. So as Kathy has already nicely introduced me, I'm Sebastian Satui. I'm an assistant professor and the director of the Vasculitis Center in the University of Pittsburgh. Very important, as much as my name, is that I do have some disclosures that are either related to some of my personal kind of grant funding, whether it's also work or collaboration with different kind of industry partners for clinical trials, consulting and advisory boards, which some of these are relevant to the talks and some of the medications that I will discuss about today. I put that on my other because I'm part of the Vasculitis Foundation, and I say that I say that very proudly as being now starting as executive board, because I'm passionate about the work that is done by the VF, by the goals, and certainly by working with all of you and on all people who live with vasculitis or PMR. So PMR, and this is a very kind of the very simplistic image of what we usually get taught on, and especially in medical school, or when someone like Google's PMR, this pops up, right? So is this an inflammatory disease that tends to occur in adults over the age of 50? We know that it peaks between the age of 70 and 80 as well, and that the incidence and the prevalence of PMR certainly continues to increase with age. And as Kathy said, kind of on my intro, I also have a specific interest on like aging and inflammation and intersection in order to kind of improve, not only understand the association between them, but also improve the outcomes of older adults who are living with different inflammatory conditions. And we usually get this message again, which it's what we get translated from the figure, that is this subacute onset of pain and stiffness in the neck, shoulder, girdle, and hip girdle. So that's it, right? So that's specifically where PMR happens, and that's the only places where PMR acts up, which is actually not correct. So PMR can also be accompanied by distal involvement. It can involve actually the knees, the wrists, and they can also have this very specific kind of swelling, and it's in the context of this other condition that's called iris 3PE with pitting edema of the hands. So other sites are affected by inflammation in PMR, and there's a lot of new kind of imaging studies that have actually confirmed this to us to better understand kind of all the structures that are involved in PMR. We do know that PMR is associated with GCA in approximately 25% of cases. And there's some debate of what does that mean when someone has PMR and can have some imaging study that shows maybe some inflammation there. And I'm not going to get too much into the weeds of it. I'll mention it briefly. I'll say that it's still something that we need to understand better. But we know that people who live with PMR from several studies do have a worse health-related quality of life compared to age-matched norms, and this is probably, of course, because of the disease, because of the implications of the symptoms of the disease, and also the steroids or the treatment that comes with it as well. Now, I think one of the kind of questions that were sent before the session was someone was very interested or very into names and understanding why the names come and why is PMR called Polymyalgia rheumatica. And I think when we usually think of rheumatic diseases, we think of the joints, right? And especially when we're talking about neck and shoulder and hips, and we're thinking particularly of the joints. But what we know, and this is why I like this figures way better, besides the fact that these are like some close colleagues of mine in Australia who developed this beautiful atlas to better illustrate how PMR, what happens in PMR and what leads to the symptoms in PMR. So PMR is actually a condition that starts outside of the joints. It's periarticular. So it actually leads to inflammation of, and I think I'm going to put my laser pointer, but it starts with inflammation that starts in the connective tissue of the tendons and of the muscles. So, right, so that's where a lot of the polymyalgia, because it's muscle structures that initially get involved. And there was also at some point, even historically, they did some muscle biopsies, which show some changes, but it starts initially in the connective tissue. And then by contiguity, it starts kind of later involving the that bursa structure. So there's little kind of water bags that we have up in here that get inflamed as well. And then eventually the joint capsule as well. So it's a condition that happens outside of the joint and then starts leading to further inflammation into the joint structure. And it has this specific kind of involvement of, again, tendon, muscles, bursa structures, and eventually the joint. And similarly, this is what happens as well in the hips. So there's involvement of the muscle groups that are around the hips, that again, the tendons that attach the muscles to the bones, and the bursa structures. And this is what leads to kind of all of the symptomatology that we see and that patients experience. So it starts outside of the joints, moves contiguous to the joints, and leads to and affecting all the structures. So it's not only the joint, it's not only the joint capsule, and that's probably what leads to a lot of the stiffness and the symptomatology and the range of motion restriction that people who live with PMR experience with their diseases active. Let me move now. And how we've learned a little bit more about this is because of different imaging studies nowadays. So we have learned from either MRI scans or PET scans that PMR is, again, not only restricted to the joints. We see this kind of increased uptake. So everything that kind of lights up red in the PET scan is usually indicative of inflammation or areas where there's increased metabolic activity. And we've seen a lot of this work as well in large vessel vasculitis or giant cell arteritis and Takayasu. And you see that a lot of this inflammation actually goes even beyond the joint, right? Sometimes we had some patients where they kind of report me like, oh, arthritis of the shoulders. But then when they have discussed the imaging with the radiologist, they actually say like, well, it's true what you're saying. We just not only see it in the articular phase, but also beyond it as well. And we see these areas that are kind of show the inflammation in the shoulders, they show the inflammation also on the hips, but also on the trochanteric bursas. We also see some inflammation in the ischial tuberosities, as you see this kind of areas that light up here, but up here as well. But you also see kind of posteriorly on the knees and even on the hands. So the fact is that new studies, these new imaging techniques have actually allowed us to better understand what specific structures are involved in order to understand, again, what happens, what leads to the symptoms in our patients, and what we need to be on the lookout for. So as I mentioned, so as we've talked, the incidence, and this is UK data, is 63 per 0.9 per 100,000 individuals in the UK. And the PMR, the incidence tends to be higher in women compared to men. And which leads to a lifetime risk is higher in women, 2.4%, than for men, that's 1.7%. And this is also data from like the Olmsted County and the Mayo Clinic studies. Which you can see that the lifetime risk for RA, which is also higher, rheumatoid arthritis, which is also higher in women and men, but it ends up being quite similar. And actually, if you start going, these are, again, at populational level, but if you start looking into age decades, the further up you go, it's where actually the prevalence, how common PMR becomes more common than rheumatoid arthritis. So PMR is probably the second most common systemic rheumatic disease in the US, and it's probably either the second or the most common disease in older adults, again, over the age of 50, and certainly even more so over the age of 60 or 65. And as much as we have this, again, simplistic view of all happens and the joint pain happens in those three areas and the inflammatory markers are high, the diagnosis of PMR is challenging. It is challenging for us in the specialty world, and it's even more challenging for our colleagues who are non-specialists, whether it's, again, primary care physicians, family physicians, or even geriatricians who tend to see patients initially when the onset of symptoms. Why? Because inflammatory disease, which you usually think of the inflammatory features as like, the morning stiffness and the joint pain and the restriction of the range of motion, can be seen in the context of PMR. But sometimes there's even more predominance of the peripheral symptoms. Rheumatoid arthritis can present in a similar way, and we know that late onset rheumatoid arthritis can also be a challenging differential diagnosis in differentiating between PMR and rheumatoid arthritis. Other forms of inflammatory arthritis, such as spondyloarthritis. There's a RS3PE syndrome, which is similar to PMR, but with this pretty significant pitting edema that presents in the dorsum of the hands. Other diseases, vasculitis, GCA as well there. Other forms of vasculitis, systemic lupus erythematosus, myopathies as well, inflammatory myositis that can lead to weakness specifically, can also present in a very similar way. And then we have the other non-inflammatory conditions. So we know that severe osteoarthritis or even infections can present in this way. Adhesive capsulitis or rotator cuff lesions. Infections can sometimes present with diffuse pain, some restriction to range of motion, elevated inflammatory markers, fever, chills, some of the symptoms that we know that happen in PMR because of this inflammatory reaction. So weight loss, fever, chills, lack of appetite, which can also be this common constitutional symptoms in both PMR and GCA, and certainly several other conditions as well that can sometimes mimic PMR. So this thought of, oh, this is a relatively simple diagnosis. People respond to steroids, which we all can also talk about how the response to steroids is not necessarily also that specific, make the diagnosis of PMR challenging in several scenarios. Reason why the role of specialty assessment, particularly to confirm the diagnosis and potentially assess patients who might benefit from not only glucocorticoid treatment, needs to come into play and needs to be considered in most patients. So this is actually a survey study that we did now a year back, or a couple years back actually. So it was published last year, talking with surveying primary care physicians, or GPs as they call them in the UK, to try to understand what are the practices regarding the care of patients with of people with PMR in the primary care setting and the referral practices. And as you can see from this first row, is that at least what the primary care physicians who actually participated in this survey, the median, like on average, was 25% were actually referred with patients with suspected PMR. So we're seeing that, again, upon the initial diagnosis or suspicion of disease, not everyone gets referred to a specialist for evaluation or confirmation of the diagnosis, which then again can actually limit some of the assessment initially. We also saw that some of the doses of glucocorticoids that were used for patients, for people with PMR initially, there was quite a significant variability. And this happens again because the practices in outside of the specialty providers can be different as well. And a lot of our recommendations, or the practices that we recommend initially in rheumatology, are guidelines that stay within the rheumatology world and not necessarily lead to collaboration or to education or information of our non-specialty colleagues. And that there was also some variability with regards to the duration of treatment as well. And this probably speaks to as well the different kind of the duration, whether from the provider or also duration of symptoms, which, as we will talk about later, can vary in people who live with PMR. And what later led to kind of this initial effort was trying to set and establish some baseline recommendations for the referral and the practices in the care of patients with suspected PMR. And this was a large international effort with representatives from different countries, not only specialists, but also GPs or primary care providers, and also patient representatives in this effort to lead to this consensus of recommendations. And the two main overarching principles that kind of were produced from this effort was, one, is that the management of people with suspected PMR should be based always on shared decision making between the healthcare provider and the patient, and take into severity of the symptoms into consideration, and also again, and when severity of symptoms, we're not only talking about pain, we're also talking about the functional impairment and how this can affect the quality of life and the daily life of everyone who's with PMR. And after that, which is, that's why I'm very happy that everyone asked that question, is that in all individuals with suspected PMR, they should be informed, preferably written. That's why we always kind of refer patients to the resources from the foundation about the potential overlap with GCA. They should be counseled about the need to seek urgent attention if they develop any symptoms with GCA. And now, then we kind of went into the more specific recommendations, which I will say that most of this were actually based on like the expert opinion or the people who were sitting in for these recommendations, given that the evidence behind them is actually relatively weak and there was really not that much evidence. But again, what most, well, actually, this was, as you can see, like complete agreement, or almost complete agreement, was that each individual with suspected or recently diagnosed PMR should be considered for a specialist evaluation. We understand that this can be sometimes challenging in areas where rheumatologists are not as available, where the waiting times are certainly challenging, but this conversation should be had like earlier on with the patient. Why? Because misdiagnosis can be, and this is only in rheumatology study, so one would expect that this number can be higher in patients who are being cared for in the non-specialty setting. But misdiagnosis can actually happen in up to 30% of people with suspected PMR. Other things that need to kind of be taken into account is that in people with individuals with suspected PMR, and again, I understand that this is certainly challenging in the context of the delays in care or the lack of access to rheumatologists. Patients with individuals with suspected PMR with severe symptoms should be referred for specialist evaluation using rapid access strategies. So similar to the GCA fast tracks that exist in Europe that are now kind of increasing in frequency in the US as well, there's some experience about PMR rapid access strategies as well in the in Europe. There's a few countries I think they're still not as disseminated, but more than that is just trying to advocate for the referring physician to advocate for patients to be seen faster. Um, Now, severe symptoms are basically, are things to consider and certainly advocate for those patients. Are patients who are having a significant inability to proceed with activities of daily living. Other symptoms that should always be prioritized for sending to consider those patients to be seen by a rheumatologist, by a specialist earlier, are anyone who has a pretty prominent peripheral arthritis, because it's important to differentiate between late onset rheumatoid arthritis and PMR. Whenever there's a concern for GCA, and this last one, which is something that I sadly still commonly see, is the lack of response to prednisone 20 milligrams. Why? Because sometimes what we tend to see is like, well, the patient did not respond to 20 milligrams, so I increased them to 30 or 40. And unfortunately, and then the symptoms kind of went away. 40, as a patient with suspected PMR who only responds to 40 or higher doses of PMR should always actually be assessed quickly, because that need for higher doses of steroids actually goes against the diagnosis of PMR. What are we doing from a diagnosis standpoint? And I know there was a question as well of tools for diagnosis of PMR, and everyone gets their inflammatory markers checked, ESR and CRP. Certainly, we did put a specific referral about what test needs to be done in the primary care setting, if you need to check rheumatoid factor or an SCCP, and the honest answer is that should be deferred to the specialist and should not delay waiting for this test before the specialist gets seen. There is at the moment still no specific markers for the diagnosis of PMR, at least talking from a blood work standpoint. But imaging studies have actually shown, and this includes ultrasound, MRI, and PET scans, to be able to actually identify specific signs and specific findings that can are more increase in sensitivity in order to identify patients with PMR. Ultrasound, which is now increasingly being used and fellows are being trained and probably becoming more and more available for the care of patients, is used particularly to identify kind of some of these findings that I've mentioned initially during this nice kind of anatomical pictures that include the subacromial subdeltoid bursitis and the biceps tenosynovitis and the bilateral trochanteric bursitis. It can really help to differentiate between PMR and other musculoskeletal causes of pain in the shoulders and the hips. MRI nowadays, which is certainly a more expensive test, availability might not be as it might not be as available as ultrasound, but the findings are the same, but it actually has a better sensitivity, so a better ability to catch them and actually to really detect this findings, and also more specific for it. It can also look into other features around kind of the myofascial inflammation and some peripheral joint images that can also allow to differentiate from other forms of disease. And finally, I already showed the PET scan kind of imaging studies as well, and certainly PET scans are even more expensive tests. But sometimes for the diagnosis of challenging cases where there's kind of either a concern for any other conditions, or there's a concern for like not the expected response, PET scan also has even higher sensitivity and specificity in order to find a kind of this specific signs on imaging that are pretty suggestive of PMR. So again, this is not something that I necessarily employ or recommend or use on a daily basis for every patient that is suspected with PMR, but it's our tools that are more available that us specialists are using more in cases of challenging diagnosis and are kind of, again, are at our availability. Now, we briefly talked about this and I briefly covered this as well. We know that there's a meaningful association between GCA and PMR. About 40% of patients with giant cell arteritis have polymyalgia or rheumatica, and we know that PMR is actually linked to GCA, and patients with PMR can later develop GCA as well. Reason again, why there was a specific emphasis on educating patients with PMR about the signs of symptoms of GCA. And although this can happen earlier in disease, there's certainly cases where people who have been in remission for their PMR later develop GCA. So this is something that patients always need to keep in the back of their heads. There has been a lot of debate in the rheumatology world about if do we need to always look for signs of large vessel vasculitis and do imaging, and again go into all these imaging techniques, and what does maybe finding some subtle inflammation or some kind of findings of what subclinical vasculitis mean for patients. And the answer is, I'm not going to go into the weeds of all this, both of the studies, but I think there's still kind of some mixed literature. And for us to do this recommendation broadly is, I think we need more information. But what I always tell any kind of fellows or trainees or colleagues who are within or outside of the specialty is that every single patient with PMR, the same way as they need to be educated on signs of giant and symptoms of giant cell arteritis, they always need to have a full review of systems when they are getting assessed for PMR, and a full vascular exam, checking the temporal arteries, checking the pulses in all extremities, checking the blood pressure in both arms. This is something that needs to happen in the assessment of all patients with PMR, because large vessel vasculitis can sometimes creep up. With regards to the treatment, and hopefully I'm good on time, but these are kind of, it's a big basic table summary of where the recommendations are, either from the British guidelines, the 2015 ACR EULAR guidelines, and then we have the French guidelines as well. And kind of in a summary, usually what we hear is this, again, starting between 15 to 25 milligrams of prednisone. 15 and 20 is usually the doses that I tend to use. And then after achieving complete resolution of symptoms, starting to taper, initially by 2.5 in every 3 through 4 weeks, with the goal of trying to reach to 10 milligrams around like 3 months or around 2 to 3 months. After that, the tapering starts by 1 milligram every 4 to 8 weeks until complete discontinuation. So this is, the nice and perfect scenario, right? Certainly, someone starts at 20, then you go down, and then you continue going down. And that by itself just roughly accumulates to almost 2 grams of prednisone. That being said, as probably many of you have experienced, relapses occur in up to 60% of people who live with PMR. And we know that every relapse means going up on the steroids, which means that cumulative doses and the risk for side effects from steroids just increase. And this is where this kind of misconception of, oh, this is a disease that you treat for 1 to 2 years is not necessarily the case, because large real world studies have actually shown that the glucocorticoid, the prednisone duration, can go between 3 to 6 years and up to 10 years in certain patients. There was this large systematic review meta-analysis that pulled data from 21 studies that actually showed that at 2 years, 51% of people with patients included in the studies were still on steroids. And by 5 years, still 25% were on steroids. And I would love to tell you that there's a way for us to identify, or that we have any data to identify who is in those subsets of people who might require steroids for longer. And unfortunately, most of the studies that have looked at this from a clinical standpoint, there's a little bit of a mix, and I wouldn't say there's a kind of a set answer. There's some studies that show that maybe age or like female sex or higher inflammatory markers or findings of peripheral arthritis could correlate with an increased risk for relapse or prolonged treatment. I don't think that's actually unanimous in most studies as well. But what we do know is that higher and longer use of glucocorticoids does still, even at the low doses, increases the risk of infections. There's some probably mixed data about an increased risk of cardiovascular disease, probably earlier at the higher doses, but we know about other complications like cataracts, increased intraocular pressure, and certainly osteoporosis as well. And until before 2022, we had some studies which were certainly not definitive, which would still just give preliminary data of what was being used for treatment as a glucocorticoid sparing agent. So we know when patients were still stuck on the steroids, they were still requiring higher doses, and we really needed to kind of go on and look for options to minimize steroid use and keep that disease under control. And there were some data on methotrexate, with, I would say probably not overwhelming results, but there's certainly experience. There's certainly patients who have responded well to it, but I don't think it's necessarily the game changer drug that most of us would be looking for in our patients to get the disease under control and get people off steroids faster. Some data on azathioprine, TNF inhibitors did not work, and they were starting to build up the data on IL-6 receptor inhibitors. So this is actually a study that we use using a large network of rheumatology practices in the US that actually includes like over 30% of practices in the US, rheumatology practices in the US. And we kind of looked into patients with our new diagnosis to the practice of PMR. And, again, we looked into specifically some factors that could be associated to an increased risk of being on steroids by the end of 2 years, some factors that were associated to maybe the providers actually starting on steroid sparing agents. But the bottom line is, as you can see, this is, this kind of weird looking plot, but if you kind of just focus on this top two kind of rows, you're going to see that even though most people actually remain on steroids by the end of the 2-year follow-up after diagnosis, only a minority of them were actually using steroid-sparing medications. And the answer for this is, well, basically that not terribly striking and solid data slide that I showed you before. The fact that I think for most of my colleagues, the data to really back up the use of steroid-sparing agents for particularly PMR was not necessarily there. And then in 2022, which I'm not going to get too much into the details of the studies, the evidence regarding the use of IL-6 inhibitor, initially Tocilizumab, with a PMR spare study, and these were all patients with new-onset PMR, showed that actually the people who were randomized to receive Tocilizumab versus placebo and prednisone actually showed that they were more likely to get off steroids and have their disease in remission. Again, not surprisingly, and this again reflects the rationale behind the use of IL-6 inhibition in patients with GCA. And then the SAPHYR study was also published, and this is where a different subset of people who had PMR, they were not new diagnosis, but had persistent disease despite steroids and required higher doses of steroids, which then again showed that using tocilizumab actually was associated with a higher likelihood of reaching that endpoint of having disease controlled and reaching lower doses of steroids. And then in 2023, the results of the SAPHYR study came around, which showed that Sarilumab, and again, in this group of people with persistent refractory PMR who were still like close to, an average of a whole year of having a diagnosis and still requiring doses of prednisone over 7.5, where most of them, those who were randomized to Sarilumab, were more likely to actually remain in remission and try to minimize steroids. And as important as the results, and certainly minimizing steroid use and keeping the disease under remission, was also associated to improvement in health-related quality of life, which is what we want, right? We are non-treating or chasing inflammatory markers. We want our patients to feel good, to minimize any kind of effects on their daily quality of life. So what we have learned from all these newer studies is that, one, who would have guessed, steroid-sparing agents do work. And that's actually important, and it's important to consider. And that's another reason why assessing who might be having a close assessment by rheumatology to see those patients who are still requiring steroids. Two, I have not necessarily talked too much about this, but the people who are at higher risk for having bad things happen with steroids, right? History of osteoporosis, history of diabetes, history of cardiovascular disease, people who are overweight, which steroids are certainly not going to help with that, need to be assessed earlier on. And we also learned that maybe having a little bit more data on how to taper steroids, and that there's some people who might benefit from faster tapering of steroids, especially nowadays that we do know that we have options that work. And although there have been some changes, I think that then the exciting stuff and the exciting point about this table is that we are not only having now, with the approval of Sarilumab in the market, now an FDA-approved option for the patients with refractory PMR, but there are several other studies that are coming in order to better understand, to better offer kind of treatment options, steroid treatment options, keep disease under control and minimize steroid kind of complications for our patients. So certainly it's an exciting time, and it's probably something that if you ask any practicing rheumatologist if they would expect at a table like this 10 years ago with regards to the study of PMR, I doubt anyone would have actually seen this coming, which is, I think it's certainly encouraging. I cannot not finish talking without the fact that part of my work is specifically focused as well on aging and inflammation and aging with PMR. And as probably some people have heard, I have a specific interest in frailty, which is the state of decreased kind of physiologic reserve, is kind of this losing of our bouncing back to stressors ability. And frailty is associated with an increase of risk of different things that we do not want for our patients, for ourselves, including hospital stays, including high risk of death, or including disability and worse health-related quality of life, and certainly side effects from medications most likely as well. And that what we showed in our initial study, and this has been replicated by data from some of our colleagues in Ireland, is that frailty and pre-frailty in patients with PMR, which might not, again, not necessarily only related to the disease, but certainly frailty is something that can happen in people with aging and several factors that go into it, is associated to worse pain, physical function, and fatigue. So they exacerbate the symptoms that already PMR is leading to us. And that the fact, and what we have seen in some other studies is that it seems that frail patients with PMR might have even a longer duration of steroids. So not only they have worse symptoms, they might need steroids for longer, but they also are potentially at higher risk for steroid side effects as well. Reason why the French guidelines actually show that besides considering comorbidities for side effects of glucocorticoids, frailty should be considered and assessed in all patients who with suspected PMR and who live with PMR in order for consideration of other treatments. And what I will say when I kind of put my geriatrics enthusiast hat on is that age is not frailty. So that's something that all providers, and I go around and speak about this, age, chronological age, the number that we have that is determined by the day that we were born, does not necessarily mean frailty. And this is something that needs to be assessed in a holistic way as geriatricians do, and certainly several of us in rheumatology nowadays do. So with that, I will conclude. I'm glad to take any questions. That PMR is one of the most common systemic inflammatory conditions. Imaging has now emerged as an option that should be considered in diagnosis, particularly of challenging cases. And it's actually a new and exciting time with the emerging glucocorticoid sparing agents that are appearing to better treat patients with PMR, better control disease, and minimize steroids. There's still several other things that we need to do, and that kind of researchers like myself that are focused on PMR are actively working on to better understand what predisposes someone to require steroids for longer, to have worse symptoms. When do glucocorticoid sparing agents need to be started? If there's some people, there's a benefit from considering those earlier, and there's some data that maybe the 6-month cutoff requiring higher doses of steroids is the point where people might need to start really having a conversation of glucocorticoid sparing agents. This, of course, in the absence of other reasons to consider minimizing glucocorticoids, like, again, we've talked about higher risk of glucocorticoid toxicity. There's a need to better refer patients with suspected PMR to specialty care, and given the limitations of our healthcare systems, to enhance communication and co-management between the primary care and the specialty service, role of imaging, thinking of drug-free remission, and something that I'm always talk, and I know there's questions about this as well, so we can talk about it more, physical activity interventions, because we know that that is a way to actually to keep independence, to regain range of motion, to minimize the toxicity from steroids, and that we need to do better and talk about this earlier as well. So with that, I will wrap up, and I will be glad to take any questions.
Okay, great. Thank you so much. You can stop sharing your screen now so we can see your face larger.
I'm back.
Thank you so much. We do have a few questions coming from the audience, and I would like to hit you with a few of those and see what we can find out for them. First, one of the questions that we had that came up earlier was the definitive test for PMR sort of thing, and you did talk about a few things, but one of the things that was added into this question was biopsy, and I didn't see that in any of your information, so that's
No,
inaccurate, maybe.
no. So like I said, there was like some historical studies, but this and some of the biopsies that are done nowadays are more in the context of research. It's not really something that it does in clinical, that is done in clinical practice at all. So unlike GCA, where we do want the biopsy of the blood vessel in most scenarios, or imaging, which is now being increasingly used, there is no kind of clinical role in clinical practice for biopsies at this point. So that's the part where like the diagnosis of PMR still remains very clinical. Certainly we can, get some aid from blood work. We can certainly recur for imaging in challenging studies, but it still remains a very clinical and in several cases challenging diagnosis.
Okay. All right. Thank you. The next question is if you have had PMR 18 years ago and now you have GCA, is there a chance that you'll have PMR again? And that kind of goes along with another question, which was, does PMR ever go away?
Fair. So first question is, like I said, GCA and PMR are diseases that are certainly associated, right? I think we still do not fully understand the full nature of that association as well. What I would say and what I'd say to most patients who have both is that fortunately, what we know that in most scenarios, the treatment of GCA addresses the treatment of PMR as well, like addresses PMR. Again, we're talking when we're talking about steroids. Steroids certainly work for both. Which PMR is this kind of more inflammatory uh, aspect or component of the disease in GCA. So that's one. And certainly now we know that IL-6 inhibition, which I think we all knew, we just needed to have the study in order for have the availability for our patients to treat both of these conditions as well. And there's been studies from the GACTA study that led to the approval of GCA that showed that this was actually effective as well in patients with GCA and PMR. I think my clinical practice also reflects that as well. So in most scenarios, I would say that even if like PMR were to emerge, it would probably, I would say it's in someone who's using tocilizumab as for the GCA doses, I would say that it should be covered. Certainly nothing is set in stone. Nothing is 100% in medicine, in life, and far less in rheumatology, which we can always get surprised. So an assessment always takes place. If there's any concerns about symptoms or atypical symptoms, imaging rule needs to be ruled out, because I've had scenarios where people told me, well, my hip is hurting, and although my GCA symptoms are controlled and I'm on my tocilizumab weekly, my hip is hurting, so I think it's the PMR acting up. But then you image and you realize that there's a fracture, right? So I would say it's not the first thing I would go, but certainly you need to discuss with your physician, consider imaging if there's something atypical going on, to certainly consider other causes of symptoms as well.
Very interesting. And since you're talking about PMR and its close relationship to GCA, one of the questions was, do you know of cases where PMR is also associated with GPA or MPA or any other form of vasculitis, or is
Correct.
it just GCA?
Okay, so I just realized that I didn't answer fully your question about the duration, that's why we also put that question initially as well. So as I showed, there can be some variability in duration, and the fact is that this misconception that PMR is a disease that lasts for 1 to 2 years is not appropriate. So we know that people have persistent symptoms, which leads to kind of their need for steroid duration as well. So this is not a disease that there might be some variability. We know that even in GCA, there's some people who after 1 to 2 years, although a minority, a smaller subset, can remain in remission even off medication. I think that that's the case for PMR as well, but it's not necessarily the case for everyone. It's certainly a minority, and that this is still a rheumatic disease. This is not a disease that a switch gets turned off at the 2-year mark, like I think unfortunately sometimes people are told. With regards to your question about overlap with other forms of vasculitis, I'll be honest in saying, similar to what I said before, nothing is 100%, and rheumatology, is an evolving specialty where we sometimes do see overlaps of diseases. I have not necessarily seen PMR with other forms of vasculitis per se. I think, again, if someone has PMR and there's signs of small vessel vasculitis. There's a lot of different conditions can present as PMR, and they can mimic PMR, and that's where like the expertise on the diagnosis and the consideration of the differential diagnosis needs to be taken into account, but not that I've necessarily seen. Then again, someone might go and look for a case report and might prove me wrong, which I'm always open to that because rheumatology keeps humbling me and surprising me every day.
Okay, well, thank you for that. The next question is interesting. I had PMR for 7 years and now I've been diagnosed with GCA. How does the consumption of sugar affect GCA and PMR?
That's a good question that I unfortunately do not have the smartest answer for because we know a lot. We certainly know that there's a link between what we eat and a lot of things that happen in our body. And if you look into this is where my interest of like aging and inflammation comes into play because we know that whatever we get exposed to, whether it's how we eat, how much we exercise, which is very important, infections, there's a lot of things that lead to us accruing or developing this more inflammation throughout life. Whether eating more sugar necessarily had a role with that development, I don't think we necessarily can say that. I think what I tell to people most of the times when they ask me about diet, and I know there's been a lot of webinars with way smarter people or more educated on this topic, so I'll defer to people to go and look into those webinars, is that I think a healthy diet and regular physical activity are the most important things. Sometimes people ask me about an inflammatory diet, and I think in the realm of vasculitis, I have not necessarily seen too much of like strong data, but I encourage people to like eat and remain as active as possible because we know that that is what, independent of also inflammatory diseases, but certainly cardiovascular health, metabolic health as well. So that's kind of my somehow trying to answer the question, hoping that we get more data.
I think that was a very fair and very complete answer. But speaking of being more physically active, we had a question about that. I'm a 67-year-old male patient diagnosed with PMR, and I used to like to lift weights to maintain activity, but now I can barely lift 10 pounds on a shoulder press because the pain is so intense. As I continue treatment, should the pain lessen so I can return to lifting, or are there other exercises that I should do that won't trigger the pain?
100. That's great, and that's something that, like I said initially, I don't think we have that much data. Um, that's a very strong interest of mine. Uh, the if there's still ongoing pain, if there's still like you always need to talk with your physician for ongoing disease activity, right? Nobody wants someone who is stiff with rip-roaring active disease to engage in physical activity that is certainly going to exacerbate this. Because again, as I said, this is also a disease of not only of the joints, but all the structures around it. And in weightlifting, there's going to be a lot of different kind of, or resistance training, there's going to be a lot of like effort that is going to put into those structures. So first of all, in that scenario, I would say pain should go down with treating the disease and the disease activity calming down. That being said, we know that later in life there's going to be some basal force arthritis. We're all going to have some degree of rotator cuff disease because we lift and we lifted things and we did things and probably in the wrong way, as we all constantly lift things in the wrong way, or we don't follow our ergonomics as much as we should. So it's a matter of working back towards that. I think it's very important that, and again, acknowledging that our joints have their baggage by themselves or their structures around it. Two, that we have a disease that has actually led to immobility, and immobility is also the worst thing for joints as well. So working towards that is important. And three, that we need to remain active, and that's the steroids that we take that take care of the inflammation are not necessarily also the best thing for our bones and for our muscles. So it's a matter of working towards that. The goal is always trying to be active since the beginning. I always tell patients that they're the better judge of what they can do and what they cannot do, but certainly the goal is building back to that. I do advocate, particularly depending on how severe the restriction is and how severe the impairment in daily function is, working with physical therapy and occupational therapy earlier on. When people fall or they have a surgery, they're immobilized, they go for physical therapy, right? When an athlete has an injury, they have to work with physical therapy to recover from that. So why would that be different from someone who is 67, who has not been able to raise their arms because of active disease, who's now working towards that, but is on steroids as well. I think building on that and that activity is very important. I will point out, and I think this will be added later to the video as well on the links, that there is, and it's now been added to the chat, that Anne O'Brien, who's actually a physical therapist PhD at the UK at the University of Keele, who we've actually had some conversations with, has actually created as part of her work this self-guide and physical activity, which is actually based on different weeks in order to be building back on that. So I think it's very important. It's a great resource. There's certainly more to do and build on that as well. And there's certainly more to actually discuss with your doctor as well. You know, it's very important to have those considerations. I certainly understand that getting access to physical therapy, getting coverage for physical therapy, occupational therapy is not the easiest thing nowadays in healthcare, but it's something to really consider because physical activity will go in line and will help with the recovery and the effect of medications, and most importantly, will help to keep function, keep independence, prevent falls. When you're unsteady, when you're in pain, your risk of falls increases. And nobody wants to be falling, particularly if there's any risk of osteoporosis or being on steroids prior to this as well. We know the steroids also kind of lead to a little bit of muscle mass loss. So the better way, and we know that aging does that to us as well. So trying to minimize that or ameliorate that by remaining active, by doing resistance training, by keeping aerobic activity is crucial.
Okay, thank you. And I just want to mention you did say, but in the chat box, if you all have your chat box visible to you today, you'll see that exercise self-help guide link is posted in there. And there's also a YouTube video that we've done that's really good on diet and vasculitis. So that's linked in there as well. Maybe that'll help answer some of those questions. And on to a new question. Do epigenetic factors play a role in PMR and GCA?
Wow. Also, like people are getting me outside of my comfort zone. The answer is there's a few studies that have actually come up recently showing some of this kind of genetic data using some UK data and then some of the US data from all of us as well, if I recall correctly, that looks further into this. How does that translate into what we do in clinical practice? So I'm more of a clinical researcher, so I'll be very honest on that. I don't think we're anywhere close to that yet. There's certainly a lot of interest into it, but like, you know, going from what we call the bench to the bedside, I don't think we're anywhere close to that yet. There's also some interest in what predisposes someone to develop PMR to GCA, and there's been also a little bit of look into that. But I think, again, for us to determine or stratify who is at risk for a worse outcome, who is at risk for developing for GCA, that's something that we still have not necessarily seen yet.
Okay, thanks. And this is an interesting question. How can you tell if you're having a PMR flare or if just the prednisone withdrawal pain?
That's a very good question, which is certainly not an easy question, not the easiest thing to differentiate. What I usually tell patients is we know that kind of going down on steroids can lead to increase in pain, increase in fatigue. And that probably something that, you know, everyone, when they start going down, they need to take into account that during the first days, your body's adjusting, right? So you need to be conscious that during those first days, it's really just kind of having just monitoring your symptoms and not necessarily always having the knee-jerk reaction of like, oh, this happened, so let's go back on my steroids. Because again, every step back has, you know, on that little nice curve that I showed, I would love that that was the scenario for every patient, but we know that's not the case. So it's important to make kind of assess it fully. One, discuss with your doctor specifically. I would say that fatigue and pain is one thing, but decrease in physical function, unable to do your things, unable to kind of do the exercise or the activities that you were able to, having the issues kind of showering again, or having the issues of like putting the shirt on, which is something that a lot of patients are really affected by, or even that's kind of scenario of like, I could not get out of bed. I had to call my partner again or my friend to really lift me up because I couldn't. So the stiffness is something that is way more characteristic, that is way more severe. And it's also assessing it not only of like pain as a symptom, but also as its implications from a functional standpoint as well. Um, Sometimes the reflection from like the reflex thought from everyone is, let me call my doctor so I can check my inflammatory markers. And we know that patients will flare even if their inflammatory markers are normal. So it's kind of having that full assessment. And I usually see it again from a functional standpoint and to kind of really tease out to better understand what's the response. The other thing to take into account is that osteoarthritis also gets better with steroids, right? So we all will have some degree of osteoarthritis, and osteoarthritis always gets better with steroids as well. So it's also kind of understanding what is acting up. Sometimes people are like, I'm flaring because it's my low back, but we know that you had a low back issues from some spinal stenosis. That is not something that we necessarily would attribute to PMR. So it's again, knowing your body, having a good conversation with a discussion with your physician, always, especially in the first days, kind of monitoring things and assessing not only just in the context of pain, but also the physical impairment, the physical function, and maybe putting a little more kind of hint on the stiffness as well.
Okay, thanks. We were actually just going to ask you about how osteoarthritis can it confuse the diagnosis of PMR, but also another patient was asking, why is the pain from PMR typically worse in the morning? And
I
is
would
that
love to
true?
have a smarter answer for that, but it's that because we know, which is very true, that inflammatory pain, and this is true for patients with even with rheumatoid arthritis or other conditions, that usually this is the way that I would love that it would be this simple, to be very honest, right? But usually mechanical pain is actually exacerbated by activity, while inflammatory pain tends to actually alleviate a little bit with activity. So that's where, that stiffness comes into play. That's where those symptomatology tends to be more predominant in the morning. That being said, I've also had patients who have told me, I'm stiff throughout the whole day, you know?
Mhm.
So it's a matter of kind of, again, everyone is different. Everyone's disease is different. Everyone has their own baggage as well with regards to like, oh, I've had rotator cuff surgery a couple more times. Well, you've had it, but you now have PMR, right? So it's kind of, again, understanding the before and after, understanding the functional implications from it as well, to better kind of tease out what is what. And
Okay.
sometimes that line is really not that kind of, simple or and like demarcated. It's more of like dashes maybe.
Okay, thank you. And here's another question. When do you expect the new drugs to be available? This patient is very interested since prednisone taper is not working along with Kevzara for them.
So Sarilumab is available now. There's the phase 3 study going on for secukinumab as phase 2. The study for secukinumab is going on as well. There has been smaller studies that actually have been presented this year at ACR. One with a JAK inhibitor as well, although I think that, again, that was a small single center study in France. There needs to be probably more work towards that. There was a negative study for abatacept. And then there's some studies with some newer molecules. Bottom line is, some of them will still take some time. I think if anything is closer to kind of the finish line at this point would probably be the IL-17s, which now both have studies on GCA and PMR. So that would be kind of, I think, what is closer to the finish line at this point. I think as well, depending on the steroid, and we know that the steroid taper that was used in the Sarilumab study, which is what I always try to use initially, was a very aggressive taper, and I have some patients who have succeeded with it. But I have some patients that they just needed a slower taper. So it's something as well to kind of to consider, right? I always say that if the study designed that 14-week taper, and this is a 14-week taper on people who were on steroids for over a year, close to a year, right? So I would love if everyone can do that, but sometimes you try, it does not work, and then you just need to do a slower taper and kind of reassess. So it does not necessarily, we always like to follow the cookbook, but in some scenarios, you do need to necessarily you just tweak a little bit what you're doing.
Okay, and one final question. This person asks, how does this affect those with scleroderma? And then says crest in parentheses.
Mm-hmm. So again, this probably goes to the point of like if people with other rheumatic diseases can get PMR, and the answer is, like I said, not that I have anyone in my clinic right now, but then again, rheumatology humbles us every single day, so I do not necessarily exclude that. If someone has scleroderma and PMR, which are two very different diseases, again, that's the part where like having those are the scenarios where I do consider imaging to really understand, because scleroderma or localized, systemic sclerosis or localized scleroderma can have some musculoskeletal manifestations as well. There can sometimes be some of issues that can lead the connective, like this, the skin tightening and the thickening that can lead to restriction of the range of motion of joints. So it's really understanding what is leading to that symptom, right? And that's where like imaging really needs to come into play and kind of again consider what is driving or what is causing the patient's symptom. So I do not, I've never seen a patient with localized scleroderma and PMR, but it's something that again, I think it's potentially possible and where some of this kind of imaging studies probably would play a role in order to really understand what is
Okay.
going on and what's the best way to help.
Okay, great. Thanks. And I just wanted to say that we did have someone ask about stress and how that affects it. And we are going to actually include in the post webinar email some webinars that we've done on stress and how it affects vasculitis. And I'm sure that that will be a good resource for everybody. And so we've run out of time. So I wanted to say at this point, thank you so much for your time that you gave us, Dr. Satui, and also to thank, of course, the Vasculitis Foundation for helping us with having these medical webinars and our sponsors, Amgen, AstraZeneca, and Novartis. And thank you again, Dr. Sui, so much for explaining this topic, which is a difficult topic for a lot of people to understand. So we appreciate that.
It's my pleasure. Thank you all for coming. I think this will be recorded, and I'm always glad to answer any questions. I think it's an exciting time for PMR for us to understand better, for us to improve the care, not only from a medication standpoint. Like I said, there's many other things to do as well. And I hope everyone has a good evening.